Bo. I am joining the HPC for the first time today as a new commissioner and chair. Our plan for today is that we're going to consider one agenda item prior to voting for the commissioners to go into executive session. And then we will be in executive session for 1 hour and plan to reconvene the public live stream at 3 o'clock. I'd like to turn it over to Colleen to talk us through the consideration of the minutes and our vote.
Absolutely. Thank you so much, Chair DeVoe, and welcome. As our Board of Commissioners know, all votes taken during remote meetings must be taken by a roll call vote. So I will now proceed with asking for any amendments to the minutes from July 13th, 2022. Do I have a motion?
So moved.
And a second?
Second.
And I will call on each commissioner present to vote, starting with you, Chair DeVoe.
I will abstain since I did not attend the meeting.
Okay, great. Vice Chair Cohen,
Aye.
Commissioner Blakeney,
Aye.
is Commissioner Cutler here? Nope. Commissioner Foley? No. Commissioner Haupt?
Aye.
Commissioner Kreider?
Aye.
Commissioner Mastrogiovanni?
Aye.
Thank you. Secretary Sutters?
Aye.
And Commissioner Roeder?
Aye.
Thank you so much. Okay, those are approved. Chair DeVoe.
Thank you, everyone. So let me explain the purpose of the executive session before we ask the board to vote to go into executive session. Today, the HPC is going to be considering the proposed performance improvement plan for Mass General Brigham. And the reason for the board to meet first in executive session is to comply with the statutory requirement under Section 2A of Chapter 60 that we keep confidential all non-public clinical, financial, strategic, or operational documents and information provided or reported to the HPC in connection with any performance improvement plan activities. It is appropriate for the board to go into executive session to discuss MGB's PIP proposal. We will plan to reconvene in open session on the live stream today following the conclusion of the executive session at approximately 3 o'clock. Are there any questions before I ask Colleen to take the roll call vote? Okay, Colleen.
Okay, do I have a motion to enter into executive session?
So moved.
And a second?
Second.
Great. We'll start with you, Chair DeVoe.
Aye.
Vice Chair Cohen?
Aye.
Skipping down, Commissioner Blakeney?
Aye.
Commissioner Haupt?
Aye.
Commissioner Kreider?
Yes.
Commissioner Mastrogiovanni?
Aye.
Secretary Sutters?
Aye.
And Commissioner Roeder?
Thank
Okay.
you. We'll now go into executive session, reconvening at 3 o'clock, and I would ask all commissioners to remain on mute until the HPC staff notifies.
Apologies for the delay. We are live.
Thank you, and welcome to all who are joining us on the public stream. Thank you for bearing with us as the executive session was held for the last hour. I am Deb DeVoe, and I am joining the HPC for my first meeting today as a new commissioner and board chair. And before I ask our director, David Seltz, to talk us through our agenda for this afternoon's meeting, I wanted to take a minute to introduce myself. And thank you, Governor Baker, for appointing me and for this opportunity. I'm truly honored to serve and to be part of HPC's work. I'm also glad that my husband, Steve, is an enthusiastic supporter for my decision to come out of retirement. I want to thank Stuart Altman, the inaugural chair of the HPC, for his 10 years of dedicated work establishing and leading the HPC, and for his wise counsel to me as he hands me the baton to take us forward. I have great respect for his legacy and will honor it. Up to now, I was on receiving end of the oversight, measurement, and reporting of the HPC, because I have worked in Massachusetts in health plans and provider organizations for my entire career. I've always respected the HPC's work, but now that I am immersing in it from the internal discussions, I'm respecting it even more as I understand the perspective of my fellow commissioners and the agency's team. I want to recognize David Seltz, our executive director. He has built and is leading an exceptional team at the HPC. We're a national leader and a model for many states, as we know. And we also know we need to keep evolving. The context for our work is changing. We enter this new chapter facing new health cost growth challenges, new inflationary headwinds with supply inflation, workforce, labor challenges, and our ambitious journey as a Commonwealth in healthcare innovation and reform has to continue. So I look forward to working with my fellow commissioners, Director Seltz, the HPC team, and all of the organizations and leaders in the Commonwealth to find common ground on managing healthcare cost growth, while we also provide the quality, access, and equity that our citizens expect. So thank you. And David, can I ask you to review the agenda for the afternoon before we go into our first agenda item?
Absolutely. Good afternoon, everyone. Commissioners and members of the public joining us online. Welcome to this meeting of the Health Policy Commission. First of all, thank you, Chair DeVoe, and welcome to the HPC for your inaugural meeting of chair of this prestigious board. It is clear in just the 2 months that you've been a commissioner and chair that your strong commitment to and engagement in the ambitious mission of the HPC and the journey of Massachusetts as a leader on national healthcare reform is very clear. And we as staff are very excited to work with you and to support you as commissioner and a chair of the HPC board. As you alluded to, today is an important milestone meeting of the HPC, and not just because it's your first meeting. Today's agenda really touches on many foundational elements of the Commonwealth's cost containment law passed 10 years ago this year. Agenda items include touching on accountability of healthcare spending through performance improvement plans, greater transparency of healthcare spending trends through the cost trends report and cost trends hearings, accelerated advancements in healthcare transformation through our Accountable Care Organization certification program, and the annual development of data-driven policy recommendations necessary to evolve and strengthen the state's commitment to healthcare reform and cost containment. So it is a big meeting today. As always, to the members of the public, the materials that we will review here today are available on our website, and we encourage you to stay engaged with us through social media channels and through our newsletter. So without further ado, let us dive right into this first important agenda topic, and I will turn it back over to you, Chair DeVoe.
Thank you. Thank you, David. So our first agenda, the discussion of Mass General Brigham's revised performance improvement plan, which was submitted to us on September 20th, 2022. Since MGB submitted their first proposal in May, I've been following the process closely as a member of the public. As soon as I was appointed to the HPC in July, I was fully briefed by staff. I met with my fellow commissioners individually and I've also been fully engaged in the review process. This has been one of my top priorities as the new chair. This is not the first time that this has been said, but it bears repeating that this is the first performance improvement plan that the HPC has ever required in the state. It's also the first ever required in the country. We took that responsibility and opportunity very seriously. Chapter 224 provided that the HPC may consult with the entity developing a proposed PIP. I can report that what took place over the summer was an extremely rigorous analytic review process by staff, our team at the HPC, discussions with commissioners identifying areas of improvement for the PIP to meet the statutory standard, and productive consultations with MGB on areas to strengthen the proposal. In executive session, the board discussed in detail the revised PIP submitted by MGB in September and the supporting data and information, focusing on the areas of improvement that were submitted by MGB and whether board members felt the proposal was sustainable. The reason this discussion had to occur in executive session was due to the confidential nature of the information and data that was included in and supported MGB's proposed strategies. There have been three main areas that the HPC has been working on with MGB to improve their proposal. The first was the level of savings. The revised proposal increased the amount of savings MGB is committed to achieving from 70 million to 127 million in annual savings. Increased strategies. MGB made a commitment to add new strategies in the current proposal, adding new payers to its pricing strategy, expanding its care management program, and adding other utilization-focused strategies. And last, the assurance of sustainability. In the revised proposal, MGB includes a clear commitment to sustaining the cost savings beyond the 18-month timetable of the PIP. At this stage, after the proposed revisions and enhanced commitments to specific actions, staff recommended that the proposal was ready for consideration by the commissioners and a public vote. I hope the public has had a chance to review the revised proposal, which has been posted to the HPC's website. I'll turn it over to David Sells and the team to walk through it now.
Thank you, Chair DeVoe. So for the next few minutes, myself and Kara Vidal will walk through both the background on the performance improvement plan and review a summary of the revised plan as proposed by Mass General Brigham for the board's consideration. So first, just as background of this performance improvement plan process and the importance of it, Chapter 224, the state's landmark healthcare cost containment bill, had a central organizing principle of an idea of a healthcare cost growth benchmark, or a target for all-in statewide total healthcare expenditure growth that was moderated and sustainable and more affordable for the residents of the Commonwealth. The key accountability mechanism for individual health plans and healthcare providers to hold their spending in line with the healthcare cost growth benchmark is through our annual performance improvement plan review process, as described on this slide. I will not go through each step of this extensive annual review process, but we'll just note that it includes a significant confidential review of entities whose spending growth exceeded the benchmark by the HPC, considerable consultation with those entities that have been referred to us, and a rigorous review of factors by the HPC board about whether a performance improvement plan was warranted. In this particular case, in January, the board took action in step 5 of this roadmap, the decision to require a performance improvement plan by vote. And today we are here to consider a vote on that plan as proposed. This is the 6th cycle of performance improvement plan review cycles, and this is the first time that we have reached this stage of the process. On the next slide, as a reminder, we can see that the board evaluated many different factors in determining whether a performance improvement plan was warranted in this circumstance, and that a PIP could result in meaningful cost savings reform. Our evaluation of MGB's spending is highlighted on the next slide, and the basis for the board's decision to vote to require a PIP in January. Again, I will not walk through each of these summary points as they have been discussed at past meetings, but did want to highlight that key factors included our analysis that showed that spending growth, commercial spending growth, was in excess of the benchmark from 2014 to 2019 for MGB, totaling $293 million over benchmark. And also that price and provider mix were important drivers of MGB's spending growth. With this requirement to file a performance improvement plan, the HPC first received a proposal from MGB in May. I will now turn it over to Kara to walk through briefly that initial proposal and focus our presentation on the revised proposal, which was filed with us on September 20th.
Thank you, David. Good afternoon, commissioners. As David said, MGB submitted its initial PIP proposal to the HPC in May, and that plan included strategies in 4 areas: price reductions, reducing utilization, shifting care to lower cost settings, and accountability through value-based care. MGB estimated that by undertaking different strategies in these categories, that they would collectively reduce their spending by about $70 million annually. Since the submission of the initial proposal, HPC and MGB staff have been in touch on an almost weekly basis as our team sought additional information to substantiate the claims in the plan and to aid in our evaluation of its merit. As Chair DeVoe laid out, the HPC encouraged MGB to submit a revised plan that did 3 things: increase the savings target, include new strategies, and provide greater evidence of sustainability. And on the next slide, you will see that MGB did file a revised proposal last week, which they estimate will save $127.8 million annually, which is almost $60 million more than their original proposal. That's about 80%. Major changes to MGB's proposed interventions include new pricing commitments, new utilization management activities, and revisions to the scope, scale, and value of some of their original activities. MGB estimates that it will generate $90 million in savings, nearly 3/4 of the total, through commercial pricing activities. And this is significant because, as David just said, we found that price and mix were bigger drivers of MGB's overall trend than was utilization. The next 3 slides will summarize the interventions to which MGB has attached savings estimates. And just as a note, we don't provide additional data here on the accountability through value-based care strategy, in which MGB describes new risk products it's developing with MGB Health Plan. If you're interested in additional detail on those strategies, they are available in the MGB PIP proposal on our website. Okay, so we start now with the largest of the categories of savings: price reduction. So in its plan, MGB states that it focused on decreasing price variation between itself and the marketplace. MGB's largest category of savings comes through rate adjustments with Blue Cross Blue Shield, Point32, and MGB Health Plan on their AMC outpatient services, which MGB estimates are worth nearly $60 million annually. MGB has also proposed to convert the pricing at its MG West facility, which is a facility licensed as an outpatient department of Mass General Hospital. MG West is currently paid academic medical center rates for its services, but under the plan, MGB would move MG West to its community hospital rate schedule with the local commercial payers. They estimate that this will generate about $15 million in savings annually. The third prong of its pricing strategy includes reducing the rates that MGB providers charge to MGB Health Plan for certain populations. Specifically, MGB reduced its rates for subsidized connector care members to 100% of Mass Health rates, which they estimate to be worth $11.9 million annually. And finally, MGB proposes to offer improved discounts to the state, which it estimates are worth $3 million annually. So altogether, MGB estimates the value of these pricing actions at $90 million annually. On the next slide, you'll see that MGB has also proposed multiple sets of interventions designed to reduce utilization. The first is expansion of its existing Integrated Care Management Program, or ICMP, which is a high-risk care management program that MGB has operated for many years. MGB's current enrollment in the ICMP is around 15,000 patients, but they anticipate enrolling over 4,000 new patients, primarily commercial and Medicaid patients, as part of the performance improvement plan. MGB cites evidence that the ICMP is effective in reducing hospitalizations, ED utilization, and expenses for enrolled patients. And they estimate that new enrollment in the ICMP will save about $15 million annually. MGB has also proposed a series of utilization management activities that they believe can collectively produce $17.1 million in savings. These strategies include reducing SNF utilization, introducing new utilization management requirements via MGB Health Plan for members with Mass General Brigham PCPs, and reducing certain high-cost imaging rates. The final category of interventions on the next slide is shifting care to lower cost settings. And I should clarify, final category of interventions with quantified savings. Under this category, MGB proposes to expand its hospital at home program and reduce its telehealth prices with select commercial payers. Since 2016, MGB has providing home-based acute care for patients who can be safely transitioned out of a traditional hospital setting through its hospital at home program. MGB states that in addition to lowering expenditures, hospital at home programs have also been shown to improve complication rates, reduce ED utilization, and enhance quality. MGB has negotiated commercial rates for hospital at home services that are below its in-hospital rates, and it estimates $1.3 million in annual savings based on the estimated commercial volume it would see during the PIP implementation period. In its virtual care strategy, MGB proposes to negotiate new prices for its specialty telehealth services, excluding behavioral health and chronic disease management, with certain commercial payers. These new rates would be lower than the parity rates that the payers were required to provide during the public health emergency, and MGB estimates the value of this strategy at $4.1 million. I want to now, on the next slide, jump to the future for a second here and give you a sense of what the board's responsibility would be long-term if the PIP is approved. So if the board approves the PIP, the implementation period would run from approximately October 1st of this year through March 31st of 2024. So that's the 18-month time period included in the regulation. MGB would be required to report periodically to the HPC both during the implementation period and for a reasonable period of time thereafter. MGB can propose amendments to the plan during the implementation period, and significant amendments to that plan would have to be approved by the board. And then the piece I really wanted to highlight here is that at the conclusion of the PIP, the Health Policy Commission must determine whether the PIP was successful. And the factors that the board can consider include whether and to what extent MGB has addressed concerns about its costs, whether MGB implemented its strategies in good faith, sustainability, and the impact of outside events on their implementation or spending trends, and other factors that the commission determines to be relevant. If the board determines that the PIP was not successful, it could extend the implementation timetable and request amendments. It could require MGB to file a new PIP or waive or delay any additional requirements to file a PIP. Then the reason I wanted to jump ahead in time there a little bit is so that we can now talk about two elements of the PIP that are not tied to a specific strategy, but those are sustainability and measurement. So as I just said, the board can consider sustainability, both in determining whether to approve the PIP and in determining whether the PIP was successful at the end of the implementation period. And you'll see on the next slide that MGB, thank you very much, made some specific commitments in the sustainability section of its revised plan. Those commitments are here on the slide, and these are direct quotes. They state that MGB commits to continuing the comprehensive market solution proposed in the PIP to address the role of pricing and cost growth in the Commonwealth. that MGB's goals for future contract negotiations with local commercial payers will include continuing to decrease price variation between Mass General, Brigham, and the marketplace, and ensuring that the value of pricing actions included in the PIP are not recouped through rate increases as evaluated in the context of underlying market rates. And MGB has committed that it will provide the HPC data and evidence of this commitment, which may include rate increase tables and other contract figures. And finally, on the next slide, a note on measurement. In order for the board to determine at the conclusion of the PIP whether the PIP was successful, it will need data and information on the extent to which MGB implemented the strategies as described, whether those strategies generated the estimated savings, and the impact of the PIP on MGB's overall spending trends. MGB's revised proposal includes several measures that it will track and states that it will report to the HPC every 6 months and supply the HPC with other information as needed, which is important for the board to receive the information it needs. The HPC can also specify additional reporting requirements as needed, such as, for example, requiring regular meetings between MGB and HPC staff, requiring MGB to report to the HPC periodically during and for a reasonable time after the implementation period, and specifying specific needed data or documents. On the last slide here, just want to put up for the board's consideration the standard for approval in the regulation. The PIP regulation directs the board to approve a proposed PIP if it determines that A, it is reasonably likely to successfully address the underlying causes of the entity's cost growth, and B, that the entity will be capable of successfully implementing the plan. As a reminder, we found that MGB's prices were higher than those of nearly all other providers in the Commonwealth, and that price and mix were bigger drivers of its spending growth than was utilization. MGB estimates that commercial pricing actions will produce $90 million in annual savings. We also find that MGB's savings target and strategies are based on a consideration of the total amount of savings that are likely to accrue to its commercial primary care population. That is, that they've taken into account that $293 million in above benchmark spending that we cited earlier this year. And finally, as discussed, we will receive data and documentation throughout the PIP demonstrating that it has been successfully implemented. So in terms of next steps, if the board votes to approve the PIP proposal, the HPC will notify MGB and it will begin implementing its plan immediately. As we discussed, they'll be subject to compliance monitoring and will be required to regularly provide both public and confidential reports. If the board votes not to approve the PIP, MGB would have up to 30 days to revise and resubmit their plan.
Thank you so much, Kara. We'll now open up the discussion to the board for questions and comments.
Madam Chair, if I may.
Please.
I want to first acknowledge the work done by both MGB and the commission staff to come to this point today. As this was the first PIP the commission required, I know there's been a lot of back and forth between the parties as they work to understand both the commission's concerns regarding price and spending and MGB's desire to address these concerns in a meaningful way. I appreciate what went into getting us to this point today. I also acknowledge that MGB is a unique asset in the state. Its work in care delivery, research, and training is notable, but yet, as Kara just pointed out, our own data shows it's expensive. The PIP, the achievement of the PIP goal of $127 million in annual savings, I think is significant. But this PIP won't change the price disparities that exist in our state. But it does recognize that price matters to ensuring that healthcare is accessible and affordable for residents of the Commonwealth. And those goals can be also addressed through the policy recommendations that are contained in our next agenda item. It also shows that there's a commitment of MGB to work on these issues over time and to work with the Commission to achieve greater affordability for residents. Lastly, I just want to add that the sustainability and measurement commitments that Kara alluded to just a minute ago to me, are as important as the dollar numbers, because working over time, I think it's important that we come to some agreement about the long-term implications of price and spending within the Commonwealth. So I will be voting to accept the PIP as submitted based on those observations.
Thank you. Thank you, Commissioner Khan. Other comments, questions, observations, Ron?
Yes, thank you. I'd like to echo what Martin has just said, and just a couple of other things. Given the marketplace today, this is a very tough time for MGB to look at cutting costs, given what we're probably going to go through over the next 12 to 18 months. And I think it's important that we see that they've agreed to work with us to get there and to achieve the 127.8 million. But just as important, as Martin said, is sustainability and to get there, because today, as we know, not only in Massachusetts, but nationally, healthcare is too expensive, and we need to do something about that. And the fact that MGB has indicated a willingness to work with us, I think is critically important, and I'm looking forward to doing that.
Good point. David Cutler?
So I want to echo the comments, and also since this is our first performance improvement plan, I think, Deb, you may recall from past meetings that I've often pushed us to do things in terms of colors: green lights, red lights, and yellow lights, and to sort of say how we think we in the Commonwealth are doing. And so I would say, in my mind, that the fact that this process worked clearly gets a green light. People took it seriously, and MGB took it seriously, we took it seriously, the Commonwealth took it seriously. And so that's a very good statement about us. And I would say that what we learn is overall is that in terms of how the PIP fits into our strategies to help the state contain medical spending is probably a yellow light. That is, there's absolutely some good things that come here, but this process by itself is fairly blunt relative to the whole set of things that have to go on in the state, some of which can be done internal to institutions and some of which need to be done through activities that are central, either through legislation or through our actions or the state's actions. So I am happy with this. I'm comfortable with it. This is not going to solve our problems. Unfortunately, we're unlikely to go out of business after your first meeting, Madam Chairman. I think it's a step in a good direction, and I'm very happy about that. But I also recognize the difficulty in sort of getting real big savings to people on a continuous basis. And so I personally, it sort of renews my interest in coming back to all those issues that we know we have to do outside of the PIP, that this process works. I give it a green light, but I think we can't rely on this to the exclusion of other things. And I would just like to, I don't know, maybe state my sense that conclusion coming out of this, that this can't be the only leg of our strategy, or even as we use this leg of our strategy, we cannot in any way reduce our efforts on the other parts of our strategy.
Thank you. Other discussion, comments? As I listen to the commissioners, I think our themes come through: meaningful cost savings, responsiveness on the part of MGB to allow us to make measurable commitments, to see measurable commitments that are sustainable. And while I completely agree with what my fellow commissioners have said, no one performance improvement plan or set of activities addresses the full range of the issues that we face with any one organization or in the Commonwealth. We look for progress, and this is a meaningful commitment to measurable, sustainable progress. Secretary Sutters?
I won't reiterate what everyone else has said. I do want to acknowledge that this is a tool, not the tool, in what has to be a broader conversation. I do also want to, because this was the first, really commend the back and forth and the commitment of both HPC and MGB. I would just put this, having lived, all of us lived through COVID, I would also just put what MGB has put on the table in the context of also extraordinary costs that all of our health systems had to engage in, particularly around the lack of organic staff and the need to bring in travelers and the like. So I would just put this in context of what the past 2.5 years have been. And if this was, pre-pandemic, I might say something slightly different, but within the context, I think we need to, just acknowledge that. And to echo Commissioner Cohen, I think this really leads into then, the recommendations that are in the cost trends report. So, I think we've landed in a reasonable place at this time on this one issue.
Thank you. Other comments, questions? Any other observations from our team, from the staff? Thank you. I think we are ready to turn to the vote to consider approving or disapproving the performance improvement plan proposal that has been submitted by Mass General Brigham. And I'd like to ask Colleen to take us through the process of voting.
Absolutely. The motion is on your screen here. I am asking for a vote to approve the performance improvement proposal as submitted by Mass General Brigham. Do I have a motion on the table?
So moved.
So moved.
And a second.
Second.
Great. We'll start with you, Chair DeVoe.
I approve.
Vice Chair Cohen.
Approve.
Commissioner Cutler.
I vote to approve.
Commissioner Foley.
Approve.
Commissioner Haupt. Approve. Commissioner Kreider.
Yes.
Commissioner Master Giovanni.
Approve.
Secretary Sutters.
Approve.
And Commissioner Roeder.
Approve.
Thank you.
Thank you, commissioners. And we look forward to moving ahead with MGB implementing and with the HPC monitoring and reporting. Thank you. Our next agenda item is the healthcare cost trends report, the 2022 report. And I'd like to ask David and David Auerbach to take us through the presentation on that.
Thank you, Chair DeVoe. And before we move into this important agenda item, I just want to take the opportunity to express on behalf of the team our gratitude to you, Chair DeVoe, for coming in late in this process and providing so much expertise and guidance and leadership, and of course to all of the commissioners who have been a part of this process for many years in developing this performance improvement plan process, our rigorous review, and for your guidance and leadership on this particular matter. And finally, do want to express gratitude to our colleagues at MGB for their commitment to working with us through this first performance improvement plan. And we look forward to continuing that work together for our shared goals of healthcare cost containment. As was noted in this previous discussion, however, there continue to be large systemic challenges facing our healthcare system. And as every year we develop policy recommendations to try to address these broad challenges, it's always important for us to start from a very data-driven perspective. What do we understand about what is driving healthcare spending? Where are those opportunities for savings, especially savings that improve quality and access? And where do we see particular outliers in pricing or in utilization? So for this agenda item, we're pleased to finally present on our 2022 Healthcare Cost Trends Report and accompanying policy recommendations. This report includes many different topics as outlined on this slide. I won't walk through each of them. Each of these topics has been presented at a prior board meeting throughout this calendar year in quite some depth. And this report, if approved today, will be up on our website for all members of the public to be able to access this report. As has been our past experience, we are always looking forward to evolving our approach to this data-driven report and having it be as actionable and digestible as possible for the public. And so as you'll see on the next slide, I just want to highlight and note that this is the second year that the report will also be accompanied by an online interactive report where members of the public and other interested parties can go to our website and be able to click through the findings contained in the cost trends report in a dynamic way and be able to hover over different graphs and charts and see the actual numbers and findings attached to so much of the work we do here. And this was introduced to much success last year, and would just note that we have adapted this interface to be available on your mobile phones. So if you are waiting in line and are bored, you can certainly pull up our interactive cost trends report and you will find much to be interested by. Before we dive into the policy recommendations, where we want to spend most of our time and discussion here today, I do think it is important to start with that data foundation. And so I've asked David Auerbach, our leader of the research and cost trends team, to select just a few of the most important slides and findings from the cost trends report to walk through for about the next 10 minutes or so. And then we will shift our discussion to proposed policy recommendations. So to give us the high flyover of some of the key findings, take it away, David.
Great. Okay. Thank you, David. 10 minutes, key findings, high flyover. Okay. It's difficult to choose, but I'll try to give a flavor of some of the most basic things that we found. Summarized here. Again, most of this is covering data from 2019 to 2020 or through 2020, but in a few cases, we have some insight into even 2021 and 22. So as we know, total spending declined in 2020, mainly because people used less care. There were still price increases that were often higher than in previous years that offset some of that decline. One exceptional category of care where there was more use was psychotherapy, and most of it was delivered by telehealth. Commercial spending growth in Massachusetts, our trend, as you'll see, had been lower than growth across the US, and we've now converged. We are no longer lower. Our price increases were higher, especially in hospitals and prescription drugs. And I'll show you some data on hospital outpatient prices, which varied more than 2 to 1 across hospitals, and price variation grew over the period 2018 to 20. So let's just click through some of these key findings. Here we're showing the change in spending per enrollee across commercial, mass health, and Medicare. And you see that it declined everywhere in the blue, although the decline for commercial spending was not as big as in the other categories. And you also see some enrollment shifts in the yellow. There was a shift in enrollment away from commercial and towards mass health, and within the Medicare program, away from fee-for-service towards Medicare Advantage. And that was happening across the country in this period. Next slide. Here again, that commercial trend. We're showing growth in commercial spending each year for Massachusetts in the orange and for the US in the blue. And we've shown this for a while, but you see that gap where we had lower growth starting in 2013 had been closing gradually each year. And now, as of 2020, our growth is no longer slower than the rest of the US, and that gap really has closed. Next slide. This is a deeper dive on commercial spending, what went down in 2020 and what went down the most. You see the biggest drops in 2020 were for that office-based professional spending. In the light blue, the office spending went down 17%. And the professional component of hospital outpatient spending, you can see in the second cluster of bars. Pharmacy spending on the right was the one category where it increased in 2020. So now I'll show a few slides. Spending is a function of utilization and prices most broadly. So I'll show a few slides on utilization trends and then some on price trends. This is the utilization slide, and this is the one where we have the most insight into even up through March of 2022, so just 6 months ago. And we can see ED utilization. Really, the main thing to note here is that use of the emergency department has not recovered to what it was pre-pandemic, even as of March of 2022. It is still lower than it was in 2019. And the biggest drop has been in potentially avoidable ED visits since that time. Next slide, please. And another troubling aspect of emergency department use is the longer stays for folks with behavioral health conditions called ED boarding. This is tracking what % of patients were in the ED for at least 12 hours. And you see that that growth in the blue on the top is really folks with mental health conditions, where the % of them staying in the ED for more than 12 hours has just increased through the end of 2021 and is almost half, almost 1 out of 2, where those for substance use disorder, that has been still high, but a flat trend through 2021. So it's the mental health cases. Next slide. And as I alluded to, the one category of care where utilization increased was psychotherapy use. And this is breaking down 2020 by quarter, and then for the 3 separate age groups below. And the interesting thing is that the % of those visits that are delivered by telehealth in the orange is over 85% for all of these age groups. And this is really one area of care that has not changed from all we know up until today. That is still what psychotherapy use looks like, is it seems to be a persistent change resulting from the pandemic. Next slide. Okay, so now moving into some highlights on prices. We saw from 2019 to 2020, price increases were a bit higher than they had been in the previous year, and that's driven by higher price increases in hospital settings. The hospital outpatient department in the middle, 4%, and inpatient settings also about 4% in 2020. And that's commercial. Next slide. Price increases we also saw for prescription drugs. The orange dot is showing average spending per branded prescription from 2017 to 2020, and that grew 11% again in 2020. And the far right whisker is showing the 95th percentile. So 5% of those prescriptions were priced about $4,500 or more in 2020. Next slide. And out-of-pocket spending for prescription drugs has also increased, especially we're focusing here on certain conditions where most of the drugs are branded. And this is average out-of-pocket spending for a 30-day supply of drugs for these categories. And you see about 50 to 60% increases for insulin, non-insulin diabetes, MS drugs, anti-arthritic drugs. Next slide. Here, another important component of spending on the inpatient side, where the spending is driven not just by prices, but also coded acuity. The amount hospitals are paid for an inpatient admission is a function of what kind of discharge it is, such as pneumonia or a vaginal delivery or a hip replacement, but also how severe that patient is, which is coded by the hospital and by the payer. And we've been tracking this for years, that coded severity has been increasing gradually each year. And this is largely not because patients are sicker, but because of deliberate efforts undertaken by the providers to increase that coding of those patients. And that trend was really continued the same in 2020 and in 2021. And that contributes about half of the inpatient spending increase along with prices. Next slide. And for this slide, what we did was, in looking at the hospital outpatient department, we created a market basket price index. Hospital outpatient departments have so many different services, from mammographies to MRIs, colonoscopies, E&M visits, that to boil it down into one figure, we took the 50 highest spend procedures across the state, combined them into a price index, and then asked how much would it cost to buy this basket of services from each hospital. And here you see that ranked from left to right, from highest to lowest. And we found a difference of about 2 to 1 in terms of how much it would pay for the same exact services at each hospital. The higher prices were found in some of the island hospitals, the specialty hospitals, and the academic medical centers, especially, as you see there. Okay, next slide. And taking that same index, we also combined the hospitals into their systems. And what we found when we did that, we looked at not only the price levels in 2020 on the x-axis, but growth from 2018 to 20 on the y-axis. And that upward trend is what's showing that the hospitals with the higher prices also had higher growth on average, which means that the prices are pulling away from each other. The variation is getting wider. And finally, tying some of this together, we then took a more comprehensive look at affordability and how this all plays into, can people afford healthcare? And we looked at that other data on typical expenses for a middle-class family for childcare, food, housing, transportation, everything that you need to buy. And we added on what we know about health insurance premiums, and this is for folks with commercial insurance, and out-of-pocket spending on healthcare. And we took middle-class families in the Boston area and the Worcester area, and what we found is adding those expenses together with the healthcare added on, those expenses for a middle-class family in the Boston area, expenses were higher than income by quite a bit, which really was a kind of a warning signal to us that, wow, affordability is seriously challenged, and healthcare is a big contributor to that. Even in the Worcester area, you were about balanced, and that was just with kind of the basic expenses of life. And so this sort of leads to some of the recommendations that David's going to go into.
Thank you, David. So that was a great flyover of some of the key findings. Again, encourage others to do a deep dive into the report when it's posted. But really wanted to now shift the conversation to both our conclusion and the policy recommendations that we're proposing to include in this year's report. This year's report is different, and it is an important opportunity, as I said at the beginning of this meeting, because this is our 10th year at the HPC, helping to lead and monitor the state's cost containment effort. And given that important milestone anniversary, we really wanted to take the opportunity this year to take a step back and really understand what have been some of the most persistent challenges facing our healthcare system over this time period, based on the data and evidence of 10 years of cost trends reports. And so in sum, as we look back over these 10 years, it is clear that the Commonwealth has made meaningful progress towards moderating healthcare spending growth. However, in recent years, that spending growth began to exceed the benchmark, with, of course, the exception of 2020, and appears likely to continue that upward trajectory. And we found that this trajectory, this trend, is being driven largely by some of these persistent challenges and failures of market functioning that have not been adequately addressed in the past 10 years. And so I wanted to really shape our policy solutions and our urgency for action around these findings. So this slide summarizes some of the key challenges that we identified after 10 years of reporting on healthcare cost trends. One, that there is excessive provider price growth and extensive variation in provider pricing that is unrelated to value. That there has been increased market consolidation and an increased shift in patient volume to higher cost or higher priced settings of care. That we continue to have high, rising, and non-transparent pharmaceutical pricing, which may not always be set in accordance with the clinical value of those drugs. The result has been steadily increasing health insurance premiums, deductibles, and cost sharing. And that shift to those costs onto employees, businesses, and consumers, and all those who bear the cost of healthcare in our Commonwealth. We've noted for many years a stalled uptake of value-based contract or payment models that would reward providers for providing high-quality care while moderating their spending growth, and a stalled uptake of innovative plan designs such as tiered or limited network products that attempt to try to steer patients towards higher value providers of care. And finally, and cutting across all of these dynamics is the systemic and persistent disparities in healthcare access and affordability outcomes across a range of factors, geographic, income, race and ethnicity, et cetera. So this year, as in developing our proposed recommendations, we saw that these challenges are persistent in Massachusetts, but also we are not alone here. Many other states are wrestling with these same pressures, and these pressures have been exacerbated by the ongoing impacts of the COVID-19 pandemic and the inflationary headwinds, specifically on labor costs and supply costs that our healthcare system faces, and that has been mentioned earlier in this discussion. Other states are evolving their cost containment strategies to reflect the current context, and Massachusetts does as well. We believe that urgent action is needed by policymakers to strengthen and evolve our approach, or else we will continue to have a healthcare system that is increasingly unaffordable for Massachusetts residents and businesses, and that will contribute to growing health inequities. So, in reflecting on these 10 years, these challenges, the approaches by other states, we developed a set of priority recommendations on the next slide for action by the next administration and legislature. There are a comprehensive set of 6 recommendations, but in developing these recommendations, we wanted to particularly highlight and prioritize action in these 3 areas. One is targeting above benchmark spending growth. As we have recommended before, there is an opportunity to strengthen the performance improvement plan process that we spent the first part of this meeting discussing. This is the primary accountability mechanism for the healthcare cost growth benchmark. Specifically, we think there are opportunities to, we recommend that the metrics used by the Center for Health Information and Analysis to identify and refer provider organizations to the HPC should be expanded to include measures that look at and account for the underlying variation in provider pricing and baseline spending that we know is endemic to our healthcare system. We further recommend the establishment of escalating financial penalties, not to impose those financial penalties, but to further deter excessive spending by healthcare providers and health plans. Second, in identifying that one of the primary drivers of healthcare spending growth in the Commonwealth and across the United States is the growth in pricing, we recommend action be taken to constrain excessive price levels, variation, and growth for medical services and for pharmaceuticals. We recommend that the legislature consider imposing hospital price caps on the highest priced services, or imposing growth caps in line with what other states have done to try to restrain excessive growth. We recommend enhanced scrutiny of mergers and expansions by our provider systems, by limiting hospital facility fees, and expanding the state's oversight and transparency of the entire pharmaceutical sector, including pharmaceutical manufacturers and pharmaceutical benefit managers, and a greater oversight and expansion of the state's role in understanding how pharmaceutical pricing is set in relation to value. And finally, as we constrain total spending growth and constrain excessive provider pricing and pharmaceutical pricing, it's important to ensure that those savings are passed along to consumers in gains in actual affordability in premiums, copays, and deductibles. And here we recommend that the Commonwealth take action to strengthen the annual health insurance rate review process and embed within that process standards of affordability for the residents of the Commonwealth to greater ensure that health insurance products are driving that affordability that so many desperately need. And that, as David Auerbach showed, is increasingly out of reach for many residents of the Commonwealth. These were our recommended areas for immediate action. I will note on the following slides, we do get into more detail about the broader set of policy recommendations, which include other really critical recommendations. But before I do that, perhaps I'll pause here and open it up for some discussion about the approach that we took this year in developing these policy recommendations, in specific these areas for prioritized action, and the overall assessment of our progress over this last 10 years, and what it will take for us to chart a path forward for the next 10 years. So with that, I'll turn it back over to you, Chair DeVoe.
Thank you so much, David. Very useful information and very helpful in understanding the recommendations and the path forward for the Health Policy Commission. Questions and comments from commissioners? Any questions or comments? I think the outline around how important the issues are, both for the providers and looking at what's changing in terms of care delivery and what's changing in terms of some of their challenges, but also what's happening for the residents of the Commonwealth and costs. Secretary Sutters? Did you have your hand up?
Yeah, I did. I was trying to find my lower hand. I know where to unmute. Can't always find the lower hand thing. I would just point out that many of the recommendations, or a number of the recommendations, are actually ones that were in the governor's healthcare bill. And I do think there will be an opportunity hopefully in the early part of the next calendar year. None of our, magic wands are, perfect, to take up some of these important issues around costs and quality that affect, all of us who live in the Commonwealth. So that's anything I want to say.
Thank you.
It's an opportunity not yet realized.
Good to hear it's there. Other comments, questions, observations? David Cutler?
So I thought the discussion was great. One thing, this may be more for David Auerbach than the commission. One thing that would be really helpful, it would be if we could get kind of very good data on exactly what's happening to wages in healthcare in Massachusetts, because that really influences a lot of what we feel needs to happen in the short run. I don't know if CHIA or we can do some kind of, quick monthly surveys every month, just saying, hey, what's going on? Are you still short staff? Have you had any wage changes, or just something like that to let us know what's happening there, because that's going to be a big influence on what we can and can't do in the next, year.
I'll jump in. I would say that we have examined some of the regular reporting that occurs through the Bureau of Labor Statistics and through our state's workforce administration. But I want to defer to Secretary Sutters here, because I know this is a topic that has been top of mind for you. I don't know if you have.
So the industry does provide does survey its members on a quarterly basis around, there's some data that obviously comes into CHIA on a quarterly basis to gauge what's happening in the industry. I I would just caution all of us, and like anything we add on to anyone, we should think about what it is we're taking off and reporting. So the burden of reporting on all of healthcare right now that was imposed by the federal government during COVID has not yet been removed. So I would suggest that we all cull through what is currently available, even if it is self-reported data, and to see if that provides reasonable proxies for us to use. I did recently decline to add another reporting requirement on health systems in Massachusetts specifically for that reason, Professor Cutler, because of where we are just in Massachusetts. But there's actually some reasonable, we collect it, we're looking at it, and the cost of travelers to augment organic staff is pretty extraordinary cost. That plus labor agreements, and not that labor agreements should not be renegotiated to be fair and reasonable, as I'm sure my good friends would say, right? But it's, and you look at the impact on the emergency room boarding for behavioral health, you may have just seen the report that came out. It's not that we don't actually have the physical capacity and the licensed capacity for inpatient psych beds. It's that they are not available because of staffing. So I think that was a long way of cobbling, of saying that you can triangulate a fair amount of data.
Great.
Thank you, Secretary Sutters. And I'll finally just add, this is the context of our healthcare system, the pressures that they under, the headwinds is absolutely critical to take into consideration here, and would highlight that we will have our cost trends hearings coming up soon at the beginning of November, and expect that this will be an important theme as we discuss with leaders of our healthcare systems how to achieve our cost containment goals in this context, and balancing the real pressures that all are under.
Good. Commissioner Foley, Tim?
Yeah, just, thanks for adding this conversation. It's one of the comments I had just about the overall policy recommendations. I think really looks good and support the direction that we're going in. But I think clearly under the workforce section, we need some more policy recommendations versus just outlining that there's a problem that we got to figure out. And maybe to David Seltz's point, the cost trends hearing provided an opportunity for us to solicit some ideas and feedback about, the cost impact, but also the needs to continue to invest and train and recruit and retain talented healthcare workers. And also the upcoming report that is due from the HPC. And maybe when we release that report, there can be some discussions about policy recommendations to strengthen the workforce and understand the impacts on the system, because we all know, and we heard it the last time we've had meetings and hearings from each of the leaders across the healthcare industry, that staffing is the major issue to address all of our quality healthcare issues, as well as some of these cost control goals. So I do think it's a conversation worthy of further engagement and some recommendations, and maybe we can build some common agreements of what we need to do, what the state should be doing to address this real concern that providers are facing every single day.
Thank you. Great discussion.
So, Madam Chair, I'm happy to just walk through the final couple of slides here on this section, and before we consider a vote on advancing the report and the recommendations. So while we highlighted these important areas for priority, and as the Secretary said, an opportunity not yet realized, we do continue to have in the report a broader set of recommendations as outlined beginning on the next slide. And some of these are kind of embedded in the three that I just walked through. And so I will not spend much time repeating myself, but of course, strengthening accountability for the healthcare cost growth benchmark, constraining excessive provider pricing. Next slide. As stated before, enhancing oversight of pharmaceutical spending, ensuring accountability for health plans on affordability. Next slide. And also, woven throughout all of these efforts, and if you have the opportunity, those of you who are watching this, to read through our recommendations, we really try to incorporate elements of equity into each of these categories, but also had its own recommendation that there is an opportunity for the state to set health equity targets and for different activities by industry to improve health equity through greater data collection, payer-provider contracts to advance health equity, following the lead of Mass Health and others. And then finally, a recommendation that includes a number of other areas of opportunity that we have highlighted in the past, including improving investment in primary and behavioral health care, examining and continuing to consider the impact of coding on patient risk adjustment, on spending and performance measurement, and finally, continued efforts to reduce low-value care. So all of these concepts are continue to be included in the comprehensive policy recommendations included within the report. And then the next slide, I believe, just wants to highlight, I think Commissioner Foley teed this up nicely. This report is, of course, an important annual report with our recommendations, but we have many different obligations and responsibilities to report on other topics and expect to do so in the coming months, some of which are very related to the impact of COVID-19 on our healthcare system. So want to highlight 3 here, which I think are most relevant to understanding those ongoing impacts in order to inform our policy recommendations. So the first will be a report on utilization of telehealth in the Commonwealth, and will include assessing impact on patient access and total healthcare spending, quality, et cetera. We do have a report that we're working on impact of COVID-19 on the healthcare workforce. Again, as Commissioner Foley highlighted, perhaps a greater opportunity in that report to identify policy recommendations and also common strategies to improve the retention and recruitment of our critically necessary workforce in healthcare. And then finally, as Secretary Sutters highlighted, the impact and growing impact of mental health and behavioral health related ED boarding. We'll have a report due to the legislature next year on our analysis of these trends, including an opportunity for recommendations as well. So those topics will all be forthcoming in the coming months, and we look forward to working with commissioners as we craft these reports. But for this, our 10th annual cost trends report, I will now turn to the final slide and turn it back over to our chair.
David,
yep.
It's Chris. Could I just lob in one suggestion on recommendations? One of the major problems you identified in your observation section was that value-based care contracts have stalled. I think we could take a firm position that we urge hospitals to change their business models. I mean, may sound like a really simple suggestion for a very complex problem, but look at the root issue here is volume, and volume-based care is what is driving it up. And there are states which are doing better than Massachusetts. There are hospital systems that are doing much better than our hospital systems in getting prepaid contracts, which puts the incentives in the right place to keep people out of the hospital, keep them healthy, invest in primary care, invest in behavioral. So I would like to urge that we consider having a firm recommendation to change business models, because if those practices don't change now, in fact, I'll even Secretary Sutter said we don't have crystal balls. We don't, but I try to stay pretty close to what's going on around the country, and everybody else does here. And hospitals, if we think we're in in a moment of stability. We're at the opposite right now. That many feel that 2023 is going to be a horrible shakeout. Where you've got recession, you got reduced subsidies from employers that because of recession, you've got inflation. We all know about nursing costs. The investment income that hospitals relied on for ballast in their balance sheet, it's gone. It's negative. Physicians are burned out. Patients are frustrated. You know, I could go on and on and on. But the point is, it's going to get worse before it gets better. And I don't know how the HPC responds to things getting worse, but it's going to get worse, and we're not dealing with a stable situation right now. And I hope that doesn't come across as a screed. I'll stop where I started, which is they need to change. Hospitals need to change their business models, and how we push that, how we monitor that. Is beyond my ability to suggest, but I do think we ought to keep our eyes focused on that. That's it.
Thank you.
No reaction? Come on, David Cutler, say something.
No, I think it's right. I think, I mean, I was agreeing as you were saying all that, right? Because
okay, good.
because
Thank you. I thought I was all alone.
No. But you know, it's sort of, it's almost like, you know, when we've dealt with this in the past, one of the issues that has come up is that even where the value-based payments, even where the payments are value basis, like say in an AQC type model, there's still underneath that is still a very substantial dose of fee-for-service payments, particularly to the specialty providers. And so that's always created these problems for us. So it's sort of like whatever level we think we have, we probably have less than that because of the way the payments are flowing down from the primary care to the specialists. And I think that's been a real problem because we wind up not having as much value-based purchasing as we think we do.
Others are figuring it out. Massachusetts is not moving as quickly as other states, in my view. And again, hospital systems in our state are not moving as fast to prepaid reimbursement as they are in other states. California, Utah, Texas, I think, Tennessee for sure, Florida. I think we're losing ground rather than making progress. Tim, I don't know. I'm not trying to put anybody on the spot, but I think I saw Tim Foley nodding his head.
Other comments? Questions?
Just to respond briefly, I would note that the recommendations do include a recommendation around increased adoption of value-based payment models, including capitated models, and would note, you know, an increased interest in primary care capitation or subcapitation. And so it is not as boldly written, Commissioner Kreider, as you suggest, but do continue to see that as part of our suite of strategies.
Great. Other comments? Any other questions from commissioners about the report or about the themes and issues that we're focused on? Well, thank you. Good discussion. And I think we're now ready to turn to Colleen and ask for a vote to approve the report for release.
Absolutely. Is there a motion?
Motion.
And a second?
Second.
Okay, start with Chair DeVoe,
I approve.
Vice Chair Cohen,
Aye.
Commissioner Cutler,
Approve.
Commissioner Foley,
Aye.
Commissioner Haupt,
Approve.
Commissioner Kreider,
Yep.
Commissioner Master Giovanni,
Approve.
Secretary Sutters,
Approve.
and Commissioner Roeder.
Approve.
Thank you.
Great, thank you all, and good discussion. We'll look at the issues with David that were raised by the commissioners. Our next agenda item is to review market changes that have taken place since the last HPC board meeting. This is a standing agenda item, and I'll turn it over to David.
Great. Thank you, Chair DeVoe. So a few additional agenda items here for the meeting today. We do have one final vote of business at the end of the meeting, but the next few agenda items will be updates to the board. So first, for our standing agenda item on recent market changes, I'm going to turn it over to Sasha Hayes-Russinoff.
Thank you, David. Good afternoon, commissioners. Good afternoon, the public. Since 2013, the Health Policy Commission has received 146 notices of provider transactions that fall into our material change notice review process. As you can see here, formations of contracting entities have been the most frequent. On the next slide, you will see that since our last board meeting, the HPC has elected not to proceed to a cost and market impact review on 3 provider transactions. First, there was a proposed joint venture between Shields Healthcare Group and Melrose Wakefield Healthcare, which is part of Tufts Medicine. The new joint venture is to own and operate a PET CT clinic serving patients in Melrose Wakefield service area, replacing an existing affiliation between Melrose Wakefield and Alliance Healthcare Services. In our preliminary examination, we found limited scope for spending increases due to the transaction. Although Shields does have higher average commercial prices than Alliance for PET CT services, the scope of any potential spending impact is limited by the low total volume of commercial PET CT services performed at Melrose Wakefield. And we did not review any evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. Second was the acquisition of Franciscan Hospital for Children by Children's Medical Center Corporation, which is the corporate parent of Boston Children's Hospital. Franciscan, as you know, is a pediatric post-acute and rehab hospital owned by a Catholic religious order that specializes in care for medically and behaviorally complex children. The party stated that the intention is for Franciscan to continue its educational, behavioral health, and rehab programs following the acquisition, and that they would invest in expanding Franciscan services to meet unmet needs. In our preliminary examination of this transaction, we found that Franciscan primarily serves public payer patients, meaning that we anticipate a relatively small increase in commercial market concentration due to the acquisition. There is some potential for increased spending if Franciscan's prices for its commercial patients increase as it joins Children's. However, there's also potential for the transaction to meaningfully improve access, particularly to pediatric behavioral health care. And the parties anticipate adding new capacity on Franciscan's campus and expanding its clinical programs. We did not review any evidence indicating that the transaction was likely to negatively impact clinical quality. In connection with our review, the HPC consulted with other state agencies involved in oversight of this transaction, including the Department of Public Health and the Department of Mental Health. DPH reviewed this transfer of ownership through its determination of need process, and the Public Health Council voted unanimously to approve the application at its August meeting. DPH has some required ongoing reporting from Children's as a condition of the approval of that application. And Children's is expected to file new DON applications, one or more in future, that will detail its plans to expand Franciscan's hospital capacity. I want to pause there if there are any questions on Franciscan. Hearing none, we can move on to the next slide. The third transaction that did not move on to a cost and market impact review was the proposed clinical affiliation between Children's and Tufts Medicine, which, as you all know, includes Tufts Medical Center. The proposed affiliation followed the closure of certain pediatric services at Tufts Medical Center, including 41 pediatric beds that Tufts plans to convert to serve adult patients. As you'll recall, that closure was evaluated by DPH's licensure division through the Essential Services Closure Review process, and Tufts and Children's proposed the clinical affiliation as a way to mitigate the impacts of that closure. The affiliation includes two components. The first is a preferred provider agreement, under which patients requiring services that were discontinued at Tufts would be referred to Children's, with Tufts receiving a discount from Children's for care provided to their risk patients. The second component of the affiliation is a professional services agreement, under which Children's affiliated physicians would be leased to Tufts to provide services at Tufts Medical Center and affiliated community hospitals and ambulatory clinics. In our preliminary examination of the affiliation, we found that there's limited potential spending for spending and market concentration increases due to the proposed clinical affiliation. Our modeling suggests that the closure of inpatient services at Tufts would probably result in many Tufts patients choosing Children's as their primary provider for pediatric services, regardless of any clinical affiliation. Children's does generally have the highest commercial prices for pediatric services and the highest share of commercial inpatient pediatric services, but the clinical affiliation itself would likely only marginally increase total commercial spending and concentration beyond what we would expect to occur even absent the affiliation. Also worth noting that for the pediatric services that are remaining at Tufts to be staffed by Children's physicians, Tufts will continue to bill pursuant to its own commercial contract terms and prices. So we don't expect a spending increase for pediatric services that are going to continue to be provided at Tufts, even though those will be staffed by Children's physicians. Also, the clinical affiliation has the potential to mitigate some of the access concerns related to the closure of Tufts pediatric services through the referral and staffing arrangements. Children's has traditionally served a lower proportion of publicly insured pediatric patients than Tufts, but Children's did join the Tufts Mass Health ACO to alleviate insurance barriers for Mass Health patients seeking to access Children's care. And Children's has pledged to work with any Tufts commercial patients whose insurance networks haven't traditionally included Children's. And we did not review any evidence that the transaction would negatively impact quality of care. Any questions on that before we move forward? Excellent. So on the next slide, you'll see we have 4 transactions currently under review. All of these received since the last board meeting. A proposed joint venture between Tufts and Acadia Healthcare, a national for-profit healthcare services provider that operates behavioral health hospitals, including in Haverhill and Dartmouth, and a number of substance use disorder treatment centers in the Commonwealth as well. The plan is to form a joint venture psychiatric hospital to be placed in Malden. The second is a proposed transaction between Steward Healthcare System and CareMax, which is a national for-profit provider focused on Medicare Advantage patients. Under the proposed transaction, CareMax would acquire all of the value-based Medicare business of Steward and act as a management services organization for that population. The third is a proposed acquisition of the private equity affiliated parent corporation of Monte Nido, which is a eating disorder treatment care provider that has national programs, operates several facilities in Massachusetts, including Walden Behavioral Care. They're planning to be acquired by Revelstoke Capital Partners, which is another healthcare private equity firm. And lastly, Beth Israel Lahey Health has proposed to acquire Exeter Health Resources, which includes Exeter Hospital in New Hampshire, and also includes a multi-specialty physician practice, a VNA, and a hospice, all serving Southeast New Hampshire and Maine. Finally, on our last slide here, In addition to our work on material change notices, our team regularly monitors applications for determination of need submitted to DPH. We've been looking at 3 of those applications in particular that are currently under review. As we've discussed at prior meetings, there's an application pending for Children's to create and expand 3 ambulatory sites. It is worth noting that an independent cost analysis for that project was recently accepted by DPH, and we're taking a close look at the findings and analyses there. The other 2 applications of note are for substantial additions of beds at UMass Memorial Medical Center in Worcester and at Boston Medical Center. Those applications sort of represent a continuation of a trend of proposed acquisitions at our major academic medical centers, and we're looking at how those might impact future patient utilization patterns and spending moving forward. So we may have more to present on those at future board meetings. That is it from me. Any questions or comments?
Don't see any. Thanks so much, Sasha.
Thank you.
Our next agenda item is to provide an overview of the LEAP certification results and the reflections from the 2022 certification process. David, I'll turn it over to you.
Great, thank you. So continuing on in our filled agenda today, we wanted to take the opportunity to report back out to the board about one of our signature certification programs, our ACO certification programs. This was a central feature of the law that was passed 10 years ago, in which the Health Policy Commission would set standards for certification for organizations and update those standards every 2 years. This important program provides both transparency to the public and to policymakers about the organization of our healthcare systems and delivering care, their continued advancement of accepting risk-based contracts, and how they are actually transforming the way that they deliver and think about care for their patients to be able to be successful in those accountable risk contracts. This is a program that is updated every 2 years. We did do a significant improvement of this program that we recognize as the Learning, Equity, and Patient-Centeredness Standards. And so wanted to report back out to the board the results that we found from this round of certification. And so with that, I will turn it over to Mike Stanek to provide our reflections and results from this 2-year cycle of certification.
Thank you, David, and good afternoon, commissioners. Earlier this year, I reported to you all that we had recertified 14 accountable care organizations, and I provided a first peek at some of what we saw in the ACO's applications. Today, I want to offer a deeper dive into the findings of the program. This past year marked the 3rd time that we've certified the main cohort of ACOs since the program launched in 2017. That, coupled with our decision to evolve the standards a bit last year, using our Learning, Equity, and Patient-Centeredness, or LEAP framework, provides an opportunity to pause and reflect on the program. This slide synthesizes a handful of the most important takeaways from the latest round of certifications. The first observation of note here has been an apparent trend over these 3 certification cycles among some of the more organizationally complex ACOs. These ACOs have multiple contracting entities within their structures that hold and are responsible for managing performance under risk contracts. Whereas in the past, we've seen some of these ACOs take a federated approach, with each component of the ACO taking its own path to meeting our standards. We saw clear changes in the latest round of certification. These ACOs are increasingly pursuing ACO-wide approaches and strategies, demonstrating more systemness and coherence than in the past. The next observation here is one that we've remarked upon in the past and indeed earlier today, and that's the relative stasis we're seeing in alternative payment methodology adoption. APM penetration is relatively high in Massachusetts. As we'll see in a moment, millions of Bay Staters are enrolled in risk contracts, but there really has been no growth in contracts or covered lives over the lifetime of the ACO certification program. Noteworthy, however, is the prevalence of downside risk in certified ACOs contracts. Downside risk is nearly universal in these risk contracts. Thirdly, we were gratified to see that the certification program's new LEAP framework, with its emphasis on ACO mechanisms for learning and improvement over time, is a good fit for the work ACOs are doing, As you'll see today, the ACOs are taking a variety of paths to data-driven, evidence-based care delivery, and they're leveraging discrete metrics and improvement targets to guide progress over time. Fourthly, in last year's certification process, we did get glimpses of the impact of COVID on these organizations. Negative impacts certainly showed up in terms of staffing challenges, for instance, the staffing of population health management programs. But COVID also spurred innovations, from widespread use of new care modalities like telehealth to the creation of new decision support tools for providers. And lastly, through our new requirement last year that ACOs provide a health equity response in their applications, we saw that ACOs are working to improve health equity in a number of ways, many of them influenced by immediate concerns like COVID or access considerations. We're looking forward to seeing continued progress in this important area. Next slide, please. Now we can flesh out these findings, starting with the ACO's risk contracts. Here you see a handful of statistics comparing data collected during our very first certification cycle in 2017 to data submitted by the ACOs last year. Over the course of the certification program to date, the risk contract landscape has remained largely the same, with small upticks in the number of risk contracts, PPO contracts, and total covered lives. Commercial and public payers continue to each have roughly half of the lives covered under risk contracts. The most significant change you can see here is an uptick in the percentage of covered lives that are in contracts that have downside risk for providers. That proportion has gone from relatively high a few years ago to very high as of last year. We did not ask about payment methodologies during the first round of certification back in 2017, but we have asked about it since. And risk contracts remain overwhelmingly based on fee-for-service payment with a global budget target. Only 6% of covered lives are in contracts that incorporate capitation. Next slide, please. Building on that last slide, I wanted to share some insights on what ACOs view as the most successful strategies so far for controlling total medical expense under their risk contracts, as well as those barriers they identified as the top challenges to controlling TME growth. We asked each ACO to identify the top 3 list in each of those 2 categories. You can see here that the majority of ACOs perceive that their care management programs, their efforts to reduce avoidable inpatient or post-acute care, and their investments in primary care or behavioral health capacity have been their self-identified most successful strategies for controlling TME growth. Next slide, please. In the orange, the most common top challenges to controlling TME that the ACOs identified were price growth for drugs and medical supplies, difficulties in translating risk contract incentives into incentives for clinicians, and the prices of providers outside of the ACO. Next slide, please. Turning now to some of our criteria for certification, HPC certification requires that ACOs foster a culture of continuous improvement, innovation, and learning to improve the patient experience and the value of care delivery. Mechanisms for achieving this can take a number of forms, including financial, clinical, and operational strategies for building an ACO-wide culture. We noted this year that more organizationally complex ACOs are increasingly consolidating clinical programming and ACO functions, effectively demonstrating more systemness. We found that certified ACOs most commonly rely on regular cross-functional meetings dedicated to identifying opportunities to improve performance on cost and quality metrics. Many ACOs regularly convene clinical, operational, and business leaders from around the ACO to discuss performance improvement goals, opportunities, strategies, and activities. While the use of cross-functional meetings varies across ACOs, we saw evidence that some ACOs are using them not just to review organizational performance, but also to encourage routine problem-solving collaboration, normalize continuous learning, offer a forum for new ideas, and spread promising practices to other areas of the ACO. Other examples of the sorts of activities ACOs are undertaking to establish cultures of improvement include some ACOs outline criteria used when selecting and developing a contractual relationship with preferred clinical partners, including quality management considerations, performance reporting expectations, and organizational considerations that include philosophical or cultural alignment. Some ACOs make ACO-wide commitments to advance primary care, such as by supporting patient-centered medical home recognition for all primary care practices, with ACO staff undergoing training to support practices with the necessary documentation requirements. ACOs incorporate quality and efficiency into funds flow, in addition to certain incentives for performance. For instance, in one ACO, 50% of a physician group surplus under risk contracts is earnable based on the degree of compliance with ACO initiatives, and 50% is earnable based on quality performance. One ACO supports an internal team shared across the organization that's charged with engaging stakeholders within the network to drive improvement in priority areas like quality, safety, and operational performance, along with any additional value-based contract-specific metrics. In collaboration with stakeholders, including clinical quality improvement committees, the ACO team develops performance plans for relevant clinical areas. One ACO reported supporting a formal quality improvement methodology in which system-wide goals are cascaded down through the organization to teams that review their practices, performance, and quality measures monthly. The teams then initiate rapid improvement cycles to meet quality targets, and balanced scorecards detailing key performance indicators are then rolled back up to the executive leadership. Next slide, please. HPC certification also requires that ACOs develop, implement, and refine programs to coordinate care, manage health conditions, and improve the health of their patient populations. The certified ACOs reported on dozens of population health management programs. Our application last year provided us with a broader window on the PHM programs that ACOs are implementing than in the past, particularly as we emphasized discrete goals against which the success of population health programs are judged, and evolution of PHM programs over time as ACOs learn from experience. In line with the Learning Health System framework, we saw that ACOs iteratively modify their programs based on performance relative to their goals. Many recent programmatic changes to PHM programs have involved staffing changes to recover from COVID-era staffing fluctuations, or improve performance on key metrics, or expand programmatic scope. For example, adding behavioral health resources to support chronic care management teams. Here we wanted to focus on two ACOs in particular, which provide illustrative examples of the types of PHM activity we see among the certified ACOs. Our first example ACO has implemented several population health management initiatives. It has a chronic care management program that assigns registered nurses and social workers to the top 1% to 3% highest utilizing ACO patients, with a goal of reducing med-surg admissions and emergency department utilization. The ACO also has an intervention that provides care coordination to patients with behavioral health readmissions or frequent ED visits. And lastly, it has a hospital-to-home program that uses community health workers to provide telephonic and home visits to high-risk patients who are transitioning from acute to home settings and are at risk of a readmission. The ACO in our second example uses a population health platform to integrate claims, EHR, and other utilization data to identify high-risk and rising risk members. The ACO operates a number of PHM programs, including medical care management programs for each of its risk contract populations that are aimed at members with multiple chronic conditions and that seek to reduce unnecessary ED visits and avoidable inpatient utilization. It also conducts outreach to members following an inpatient discharge to provide care coordination in the community. Next slide, please. HPC certification requires that ACOs seek to integrate behavioral health into their care delivery models. Certified ACOs collectively identified 43 priorities shaping their integration strategies, many of which can be grouped into the categories that you see here. Many of the ACOs are focusing on physical and/or virtual co-location of primary care and behavioral health providers, as well as building PCP capacity to manage low and moderate behavioral health conditions within the medical home. Building capacity in primary care for behavioral health screenings and referrals is a common emphasis for ACOs. Some are working to provide primary care practices with timely access to behavioral health resources through an embedded behavioral health clinician or access to a centralized behavioral health referral coordinator. Some ACOs have developed standards for depression screening, prescribing guidelines, and resources for patients and providers. Some have developed emergent and urgent referral workflows to a dedicated behavioral health integration team. Recognizing that building behavioral health capacity can be critical for furthering integration, ACOs are providing financial support for hiring of behavioral health staff and redesigning office space to support co-location. We also see ACOs providing infrastructure support for information sharing across settings via a shared electronic health record platform. They also facilitate e-consults to support primary care providers in prescribing medications for patients with complex needs. And they support clinical staffing and workflow development to support emergency department diversion. One ACO provides resources for a social work team, a component of the organization's population health management team, to focus on behavioral health care within primary care practices on a payer-blind basis. While another developed a common behavioral health conditions prevalence dashboard that its ACO operations teams can share with practice sites. Next slide, please. Certification further requires that ACOs seek to integrate social supports into their care delivery models. We have seen that the certified ACOs have implemented health-related social needs screenings in primary care for things like food insecurity or housing instability, and they have implemented referral activities, often with an initial focus on their mass health populations. Again, we'll draw from two particular examples to provide a sense of how the ACOs are approaching this requirement. The ACO in our third example uses validated health-related social needs screening tools to assess patient needs in 7 domains. The ACO maintains a dashboard in Tableau that provides monthly updates on the number and rate of screens administered, positive screens, and referral outcomes. Its data can be filtered by numerous characteristics, including age group, ethnicity, and race. Patients who screen positive for a social determinant may choose to see a patient resource coordinator, and the ACO also uses an electronic platform through which a resource database may be searched, referrals can be made to social service organizations, and the results can be imported back into the electronic health record. Another ACO uses a screener for health-related social needs that is available in 7 languages. Patients are screened in 8 domains. Positive screens result in receipt of an electronic tip sheet and/or a referral is placed for additional assistance with the help of a community health worker. The initial focus of this process has been for the mass health population, but payer-blind administration of the screening tool is currently being piloted in a number of the ACO's practices with the assistance of expanded community health worker staffing. Next slide, please. HPC certification requires that ACOs collect and use information from patients to deliver and improve patient-centered care. Certified ACOs most commonly pointed to their use of standardized patient experience surveys to gather information on patients' experiences and preferences, though some also pointed to their use of patient and family advisory councils for this purpose. Continuing with our practice here to use a few examples to illustrate the sorts of approaches that ACOs are taking in this area, the ACO in our 5th example engages a vendor to administer patient experience surveys after nearly every encounter, collecting thousands of survey results each month. Practice managers receive monthly reports on these results from the ACO, have a key performance indicator linked to patient experience, and enjoy access to a web portal where data can be pulled by practice and provider. Reports display question-level response results and allow for comparisons to national benchmarks. Another ACO relies on its Patient and Family Advisory Council, or PFAC, to understand patient experiences and preferences. Key updates from PFAC meetings are presented at huddles of the administrative team responsible for operationalizing projects and programs of the ACO. Through a feedback loop structure, the team identifies how issues identified by the PFAC could be addressed through its work, and updates are shared back with PFAC members. The ACO in the 7th example uses a vendor to distribute surveys to all ambulatory patients who have a mobile phone and/or an email address. Responses are aggregated by practice site and characterized by themes. For example, access, coordination of care, provider, staff, or wait times, as well as an assessment of whether the patient interaction was positive, negative, or mixed. Detailed response summaries are prepared by practice site. High-level summaries of patient interactions are also prepared by region. The survey also collects patient demographic information on race and language. Next slide, please. We require ACOs to show us how they use the information gathered on patients' experiences and preferences to influence care delivery. And we saw a variety of approaches with this information informing activities ranging from organization-wide quality plans to ongoing process improvement work at the practice level. Some ACOs are using this information to inform ACO-wide priorities for improving care delivery. Some ACOs are using this information to support practices. For instance, one ACO is tiering its practices. Based on their relative performance on patient experience indicators, practices have either biweekly, monthly, or quarterly touch points with patient experience coaches. One ACO regularly distributes patient experience survey results to practices to encourage improvement at the practice level. Some ACOs have used patient experience or other data to design training for frontline staff on improving patient-centered interactions, focusing on topics like communication skills, demonstrations of empathy, and telephone and visit standards. One ACO used feedback from patient experience surveys to improve and customize a large-scale telehealth platform that was initially stood up during the pandemic as an off-the-shelf tool with minimal customization. Survey feedback was used by the ACO to take steps to integrate the platform with a new patient-facing app, rebrand it, improve its usability, and support multiple languages. And finally, another ACO used feedback provided by PFAC members to finalize plans for a flu immunization outreach strategy as the first step in launching a series of text outreach campaigns to patients. Next slide, please. Go one more slide in the future. Actually, in the interest of time, maybe we should skip ahead a few more. One more? Okay, great. Okay. As you know, commissioners, we're very interested in exploring ways that the ACO model is being used and can be used to advance health equity. Our application last year touched on health equity in two ways: by requiring a dedicated health equity response that described intentional efforts on the part of the ACO to address health inequity, and by more general survey questions on areas in which the ACO has taken steps to promote equity in its care delivery models or within the ACO. Data from the latter question is displayed here. As you can see, all of the ACOs reported taking steps with respect to provider or staff training in an effort to improve health equity. And all but 3 ACOs reported taking steps on provider or staff recruitment, quality improvement strategies, and telehealth access or usability. Next slide, please. With respect to the health equity responses submitted by the ACOs, these generally fell into 3 categories. Some ACOs described efforts focused on immediate needs revealed by the pandemic. These responses described efforts to address racial and ethnic disparities in COVID vaccination and treatment, using a variety of individualized outreach efforts, new relationships with community-based organizations, and experimentation with non-traditional healthcare settings. For example, a vaccination ban aimed at underserved communities. Other health equity responses focused on access inequities, particularly between English and non-English speakers. These efforts focused on strategies like incorporating translation services into new telehealth platforms, or working to increase enrollment on healthcare portals among underrepresented populations, while translating the portal and a variety of patient-facing materials into multiple languages commonly spoken by the patient population. And finally, some ACOs looked at racial and ethnic disparities in a variety of health outcomes, including blood pressure control, asthma complications, and birth outcomes. And they are conducting additional outreach and interventions like remote monitoring, in-home services, and deployment of dedicated staff to tackle these disparities. All of these interventions provide a foundation on which to build going forward. I'll stop there, commissioners, but I'm happy to pause here and take any questions you might have.
It's interesting that some of the strategies really speak to the issues that Commissioner Kreider was raising earlier around changes to the business model and seeing some progress on steps towards that in terms of which levers are the ACOs are incorporating. David Cutler?
I wonder if we'd be able to get some of the financial information from some of the ACOs, particularly the ones that are doing a lot to try and reduce utilization, because because they're doing all the things that we think ought to be effective, and yet we know that overall costs are going up. So I'm sort of curious about, is it just that it's being overwhelmed by other things? And if so, what is that? Or is it that the things they're doing are great for patient health, but maybe they're not bending the needle so much on the cost side? So I really just love to be able to like do a dive into some of the financial stuff for them.
Yeah, let me echo that. Mike, great presentation. What I guess is clear, my concern is that the N is small relative to, the 4.5 million people or 6 million people. I think it'd be great if we could have a simple spreadsheet that had, ACO 1 through 14, the number of individuals that are in each one of those, and the financials that David describes, the average contract size, the percent of savings that are generated by each one of those initiatives. I'm not talking about a big report here. I know you guys are busy all the time doing reports, but a simple spreadsheet just with a couple of highlights to get us thinking would be helpful.
Sure, and we are in the process of updating some of our learning and dissemination materials, which include all the things that we can publicly put out. A lot of the information that we collect is held confidential, but everything that we're...
To be clear, I keep it confidential. Just call it ACO number 4. We don't need to know the names to begin to think about the implications of this and how to push it.
Thank you. Great. I expect a lot of interest and questions. Thank you. Any other questions or observations by any commissioner?
I will just use my prerogative to weigh in here too, and thank Mike Stanek and the entire ACO certification team. It is a full team of people that work every year to run this incredible program. It really is a unique program and an opportunity for us to collaborate and learn from our ACOs. And I also want to thank the members of the ACOs because they do put together a lot of work in order to fulfill these certification requirements. And as you said, Commissioner Kreider, one of the great things that we can mine from once we have all of these results, one of the things we really try to do is then say, what are those areas of interest where we can take this information, examine it, analyze it to inform both where we want to evolve this program, but also generally where we want to evolve our policy recommendations. So I would note, I just looked it up. We did do a series of briefs when we, I think on the last round of the certification, and we estimated about 2 million Massachusetts residents are covered by the HPC certified ACOs. So, about 1 in 3 Massachusetts residents are a member of one of these ACOs. So while the number of ACOs is small, their impact is wide. And I think, again, a great opportunity to be able to kind of provide those summary statistics and to board members, but also to the public. And so thank you, Mike. Thank you to the entire team. Great work. And we're excited to continue to evolve this program.
Thank you, David. So now we'll turn to the final agenda item for today, which is our executive director's report. And David and other members of the leadership team are going to provide a report and a few agency updates. David?
Turn it right over to our Deputy Executive Director, Colleen Elsemeyer.
Thank you, Director Seltz and Chair Javot. I will be quick. On the next slide, I am very pleased to announce that we are hard at work planning for the upcoming cost trends hearing, our 10th annual cost trends hearing. The 2022 annual healthcare cost trends hearing will be held on Wednesday, November 2nd at 12 p.m. I am also very pleased to announce that the hearing will be an in-person event this year for the first time since 2019. The theme of the event is HPC 10, charting the path for cost containment in the next decade. So we'll be looking back on 10 years and looking forward for hopefully the next 10 very successful years. This is truly a seminal event every year, but even more special this year as it's our 10th, obviously. We have a new chair and Chair DeVoe, and it will be Governor Baker's final cost trends hearing appearance as governor. Yes, the governor will be joining us in person at this event at Suffolk University Law School, and Attorney General Healy will be providing pre-recorded remarks via video, so joining us as well. So very exciting. The registration is live. The URL is listed on the slide. You can also find it on our website and our Twitter page. We're going to have limited in-person attendance. We are requiring COVID vaccination attestation as you sign up to register. So please register now. We'd love to get as many folks there as possible. I hope you all can join. If you can't join in person, of course, it will be live streamed on our YouTube channel for you to watch there. More info to come. Watch this space. And then on the next slide, I'm also pleased to release the public meeting calendar for 2023. This is our board meetings, our committee meetings, our advisory council meetings, our cost trends hearing, all of our 2023 dates. These are on our website as well, mass.gov/HPC. Mark your calendars, save the dates for next year. And that's it for me. Turn it back to Director Seltz for our budget.
Thank you, Colleen. And for our final agenda item of the day, did want to return to our HPC operating budget, an annual business activity of the board to vote to approve our budget, which is set every year as part of the annual state budgeting process. So I will go very quickly through this, but maybe at the end, we'll leave some time for questions if there are some along the way. So first of all, I think it probably goes without saying after the last 3 hours of us together on the Zoom that we do expect to have a very busy 12 months ahead of us at the Health Policy Commission, including oversight of our first performance improvement plan, which was approved at the beginning of this meeting, as well as a number of statutorily required reports on impacts of COVID-19 and our ongoing work on priority areas. So for our budget for this year on the next slide, as a reminder, our budget is set every year in the state budgetary process, the budget amount. It is assessed to acute care hospitals, ambulatory surgery centers, and health insurance companies for that total amount. That is something the HPC operates. So for this fiscal year, which runs from July 1st to June 30th, we requested funding of our account at $10.8 million, which represents a 3.5% increase from the previous year. We were pleased to see, as you'll soon come to know, that amount was approved by the legislature and ultimately the governor and was included in the final budget. This is what we consider kind of a maintenance of effort request, in so much as it will continue to support our core duties and responsibilities of the HPC as statutorily required. Additionally, we did have some additional funding for 2 grant programs, which we asked to continue that funding into the next fiscal year. That request, I think, is still pending. On the next slide, we can see how our budget breaks out of that $10.8 million into some broad categories. By far, the biggest proportion of our budget is the payroll of the HPC staff. The second biggest portion that I will highlight here is consultants and contractors. These are the experts that we work with, particularly on our market evaluations, but really across all of the work of the HPC. We do work with experts, and so set aside a portion of our budget every year to be able to work with the best people on projects as they arise. And generally try to keep our general administration, rent, utilities, and IT expenses low. On the next slide, in terms of our payroll, you can see we have actually maintained a very stable overall FTE count over the past 6 years, ultimately between 60 and 65 employees. On the right-hand side, you can see how that breaks out internally into our departments, which I think broadly align with our policy priorities of advancing healthcare transformation, market oversight and transparency, and research and cost trends. And you can see that there is a pretty even split among FTEs among those policy priority areas and departments. With the additional 3.5% budget, most of that increase will be dedicated to the payroll account and will allow us to hire a few more staff at the HPC, which will be very important as we have a number of new mandates from the legislature that did not include additional funding. And so we will need to accommodate these new mandates within our existing staff and budget. On the next slide, we can see the history of the budget requests throughout this process, and can see that the Governor Baker signed the law with 10.8 million in the final budget approved on July 28th. On the next slide, I won't go through this, but I did want to highlight that the budget also included a number of new work for the HPC, including that report on behavioral health related ED boarding, which I mentioned earlier. Other items included here, which we will be back to talk about at future meetings. And then on the next slide, again, there were a number of additional new mandates and responsibilities through landmark legislation to improve mental health care. Again, perhaps we'll leave this for a future meeting to go through in detail, but suffice it to say, a number of new activities and responsibilities from the legislature at the end of the legislative session, which will require our attention this year. On the next slide, then we come to an approval of the operating budget as authorized in the state budget and also as overviewed here today for fiscal year 2023.
Thank you so much, David. Any question from commissioners before we turn to a vote? Any questions? Okay, Colleen, can I ask you to lead us through the vote process?
You absolutely can, Chair DeVoe. Do I have a motion to approve the budget?
Motion to approve.
Okay, in a second.
Second.
Thank you. Okay, Chair DeVoe, how do you vote?
Approve.
Vice Chair Cohen?
Approve.
Thank you, Marty. Commissioner Haupt?
Approve.
Commissioner Kreider?
Yep.
Commissioner Master Giovanni?
Approve.
And Commissioner Roeder?
Approve.
Thank you.
Thank you, commissioners, and apologies for speeding through that. Happy to answer any questions you may have offline. We have a number of meetings coming up in the next couple of weeks. We have our advisory council meeting next week, October 6th, followed by committee meetings the following week. And of course, as Colleen outlined, our annual cost trends hearings on November 2nd. So a number of important meetings over the next couple of weeks. So we look forward to seeing you in this Zoom room, and for all of the members of the public, thank you for your participation and engagement in the work of the HPC. And we will be here on your regular YouTube channel moving forward. Chair DeVoe, any final words on this historic meeting of the HPC?
Thank you for a very productive meeting, important work, and look forward to the future.